The pathophysiology of ARDS. ARDS is a life-threatening condition characterized by acute diffuse lung injury leading to non-cardiogenic pulmonary edema, severe hypoxia, and respiratory failure. It is caused by direct or indirect lung injury, triggering a cascade of inflammatory and permeability-related changes that impair gas exchange. We're going to start with the inflammatory response and increased permeability. ARDS begins with an uncontrolled inflammatory response triggered by an initial result. This can be pneumonia, sepsis, aspiration, or trauma as the initial insult. The activation of neutrophils, macrophages, and pro-inflammatory cytokines such as TNF-alpha, interleukin 1, interleukin 6, and interleukin 8 leads to the release of reactive oxygen species, ROS, proteases, and inflammatory mediators. This results in damage to the alveolar capillary membrane, causing increased pulmonary endothelial and alveolar epithelial permeability. So let's explain pulmonary endothelial permeability. The endothelium of pulmonary capillaries becomes disrupted, allowing plasma proteins, fluid, and inflammatory cells to leak into the interstitium and alveolar space. Damage to type 1 and type 2 alveolar epithelial cells will further disrupt the alveolar capillary barrier, promoting alveolar flooding and protein-rich fluid. Now let's talk about alveolar flooding and surfactant dysfunction. The leakage of protein-rich fluid into alveoli leads to alveolar flooding, impairing normal gas exchange. Additionally, damage to type 2 pneumocytes disrupts the production and function of pulmonary surfactant, a substance essential for reducing alveolar surface tension. Without sufficient surfactant, alveoli collapse, leading to atelectasis, which is alveolar collapse, and worsening hypoxia. The combination of alveolar flooding and atelectasis results in a ventilation-perfusion mismatch and intrapulmonary shunting, where deoxygenated blood bypasses the ventilated alveoli, leading to refractory hypoxia, which is hypoxia that does not improve with supplemental oxygen. Patients with ARDS often require mechanical ventilation due to respiratory failure. However, improper ventilatory settings can exacerbate lung injury. There can be barotrauma, which is high airway pressures damage alveoli, volutrauma, which overdistension of alveoli leads to further epithelial damage, atelectrauma, repeated opening and closing of alveoli causes shear stress, which worsens inflammation. Biotrauma, as well, is mechanical stress that amplifies the inflammatory response. So to mitigate VILI, low tidal volume ventilation, lung protective strategy is often used to further lung injury or to help prevent further lung injury. So there's some risk factors for ARDS. ARDS can result from direct or indirect lung injury. So direct causes can be like pneumonia, aspiration, inhalation injury, pulmonary contusion, near drowning, and some indirect causes can be like sepsis, which is the most common, major trauma, pancreatitis, massive transfusion, or drug overdose. So in conclusion, the hallmark of ARDS is a self-perpetuating cycle of inflammation, alveolar damage, and impaired gas exchange, leading to profound hypoxia and respiratory failure. Understanding this pathophysiology, which includes alveolar and endothelial permeability changes, surfactant dysfunction, shunting, and ventilator-induced injury, is definitely a crucial part for effectively managing and providing treatment strategies for ARDS.